All right, hello again, everybody, and welcome to Module 6. In this module, we're going to be covering virology. Now, virology, it's going to be pretty intense. There's 114 slides, but there's a lot of different viruses that we need to cover. We're just going to do a general overview here. Your quiz is only 20 questions, but those 20 questions are derived directly from this lecture, so it's important for you guys to follow the objectives and to listen to this lecture and take notes as you go, because the quiz comes directly from this lecture again. So here are your objectives for you guys to just go over at your own time. Um, so let's just get right into it. So virology is the study of viruses. I mean, that's kind of uh, it speaks for itself basically because of the name. So viruses are obligate intracellular organisms, and they're some of the smallest infectious agents known uh, to mankind, and they range in size. So a virus can be as small as 20 nanometers, and they can be up to size of 300 nanometers in diameter. They're incapable of growth or replication outside of a living cell, and they're considered by some people to be an inert biochemical particle. But viruses come from a variety of specimens, and they could be classified in a few different ways. Um, Laboratory diagnosis is important because viruses cause different diseases. There are some diseases that can affect all the various organisms. So organs, I mean, so we could have some viruses that are going to affect your liver, some that are going to affect your gastrointestinal tract, and then the most common viruses that we hear about or come in contact to are respiratory viruses. So viruses are both classified on the basis of their genomic nucleic acid. So basically, a virus can be classified as one that either has RNA or DNA, but viruses are not going to have both RNA and DNA present. They're going to have one or the other. A viral nucleic acid can be single or double-stranded. It can be linear or circular, and it could be positive or negative sense. It must carry the genetic information to synthesize the proteins and nucleic acids necessary to replicate the virus. Otherwise, it's just inert. And the viral genome codes for outer protein code and other proteins that are required for viral production that are not provided by the host cell. So some of the proteins in a virus are going to be structural, which means that they only become incorporated in the makeup of the virus particle. And then there are proteins that are part of the virus that are non-structural, and these are the polymerase enzymes that help it replicate. So the outer shell of a virus is that surrounds and provides protection to the viral genetic material is called a capsid. So it's just the outer shell of a virus. The viral capsule can be spherical shaped, and it's called an icosahedral or helical in shaped. And then the new protein capsid and the viral nucleic acid comprise what is known as a nucleocapsid. So it's the protein capsid and a nucleic acid. So a virus particle is also known as a viron. So it can consist of the viral genome and its capsid only, or may have an additional component. So some nucleocapsids are going to be an envelope, or some just aren't present. Um, an envelope is a phospholipid bilayer that surrounds the nucleocapsid of envelope viruses. So viruses are going to be either enveloped or non-enveloped. So viral envelopes are of the host cell's origin, and they're acquired as the nucleocapsid buds out of the host cell and acquires the bilipid layer membrane of the host cell. So basically, to try to break this down for you guys a little bit, so it's more understandable, viruses are just going to be simply made up of nucleic acid particles. So a virus is either just going to be an RNA strand or a DNA strand. It could be linear, circular, um, stranded DNA or RNA. And then most viruses are going to be encapsulated in the capsid, but then other viruses are also going to have an envelope on top of that. So essentially, a virus is just genetic makeup with a capsid. Sometimes they have an envelope and sometimes they don't. And that's really DNA and that envelope really helps us classify what type of virus we have. So it makes it a little bit easier for us as laboratorians to diagnose which virus particle we might be dealing with. So viral replication, so essentially how a virus replicates and creates more viruses and essentially and eventually will cause an infection because we have an overgrowth of viruses is going to be called viral replication. So it's important for you guys to note the steps of viral replication because it is a quiz question. And there are several steps. So the first step in viral replication is attachment and absorption. So complementary receptors on the surface of a host cell and the virus are allowed to attach to the that host cell, and then this virus is actually going to be absorbed by the host cell. So if you think about it this way, if we have like a blood cell or something like that, and the virus is going to attach to it, and it's going to be absorbed inside of that cell, and that's where penetration happens. So after attachment to a susceptible host cell, the virus enters the cell by phagocytosis or endocytosis, or is usually the case for envelope viruses, fusion of the viral membrane and the cell membrane. So basically, a virus cell is going to be phagocytized and it's going to be eaten up by a cell, like in this case, maybe a white blood cell, or it's going to be enter the cell by endocytosis, or if the virus has an envelope, basically that virus's envelope is going to fuse to the cell membrane, and that virus is eventually going to get inside of that cell. What happens then is uncoating. So once the virus has gained entrance into the host cell, the viral capsid is removed, probably by the host's enzymes, and the nucleic acid is released to do its work. The viral genome must be able to direct the host cell to make the required nucleic acid component and the proteins needed by the virus. So essentially what's happening here is the virus is going to get into the cell, it's going to uncoat its capsid, so then it just becomes free-living RNA or DNA molecules. So then what happens is an ellipse period. During this period, many copies of the viral nucleic acid are produced during the replication cycle, as well as enzymes required for further synthesis and structural proteins which make up the viral capsid. So during this time, an intracellular viral synthesis is happening, but there's no visual evidence of the presence of the virus within the cell. So essentially what's happening after this point is the cell is using its host cell's information to replicate. So most of you guys have taken a cellular biology course and know that our double-stranded DNA gets broken apart, it's copied, and then it's made into RNA. That RNA turns into transfer RNA, and then that transfer RNA is going to be replicated by another protein, and then we're going to make a new DNA strand. And that's essentially what a virus is doing, but it's using our cell information to do that. So essentially a virus just is like a parasite. It uses our information to make more viruses than eventually are going to be released. So the next stage then would be maturation. So during this period, the viral capsid is assembled and the viral genome is inserted, forming the nucleocapsid. All the work is being conducted: nucleic acid synthesis, protein synthesis, and random assembly of these components into the nucleocapsid. And this is happening at a molecular level. So then once a new virus is made, matured, and it formed in its nucleocapsid, then it's going to be released. So the new virus produced leaves the whole cell through cell lysis or through budding and exocytosis. And these viruses essentially move on and do it again, enter another cell to replicate and go through this whole process again. So it's hard to understand, but yet it's easy to understand. Basically, the virus is going to enter our cell, use our information to replicate its DNA, form another viral cell, who's then going to leave that cell and move on to the next one and keep replicating. Okay, so sometimes our body have well, not sometimes, but our body has a natural immunity to some viruses. Many viruses use highly sophisticated mechanisms for cellular invasion to the host cell and evasion of our immune system. But then what happens is that our immune system is going to recognize that these viruses are foreign antibodies, and it's going to deploy our mechanisms. So one of the first mechanisms employed by our host is known as innate immunity. All of you guys at this point should have had immunology, so I'm just going to do a quick brief overview here. So what happens is once um, our body recognizes the viruses as foreign objects, the body is going to produce antiviral proteins such as interferons and complement. So interferon alpha and interferon beta activate natural killer cells, which limit viral production by recognizing and killing virally infected cells. And this process is known as antibody-dependent cell-mediated cytotoxicity. I'll say that again slower. Antibody-dependent cell-mediated cytotoxicity. So then we also have interferon gamma, which is secreted by natural killer cells, and this activates our macrophages. And these macrophages prime our immune system for an adaptive immune response. So with this adaptive immune response, the cytoplasma proteins called complement are going to be able to protect us against a viral infection by damaging the outermost layer of envelope viruses or coating our receptors, or coating the receptors of undeveloped unenveloped viruses. So our adaptive immunity is going to involve producing antibodies, and these antibodies are going to be specific for viral infections. So one of our antibodies is known as IgA. So IgA can prevent viruses from binding to our epithelial host cells that line our mucous membranes of our respiratory tract, gastrointestinal tract, and our urogenital tract. So basically, if the virus cannot bind to our surfaces and attach to our cells, then they cannot infect our cells. We also have IgM antibodies. This is one of the most potent antibodies against viruses because it's considered a neutralizing antibody. So this antibody is able to coat viruses and prevents them from infecting host cells. So this class of antibody is our primary force in the development of a lifelong immunity to certain viral infections such as like chickenpox or measles. So our IgG antibodies and our humoral immunity or our adaptive immune response is essentially the mechanism that happens whenever we introduce a vaccination. So we're gonna put weakened antibodies in our system so that we could develop specific antibodies that are going to target these viruses and kill them so that we can't get an infection. IgM antibodies are produced during an early stage of the immune response. So these antibodies are our primary response. So IgM with our IgG antibodies are able to provide strong defenses because they're gonna coat these organisms and essentially get rid of them before they have a chance to replicate. From there, we have cell-mediated immunity, which provides assistance by recruiting our cytotoxic T lymphocytes, so our lymphocytic cells, and these lymphocytes are actually going to kill virally infected cells. So whenever you look at a CBC, and again, this is something that you guys might be noticing is that all of our courses are kind of tying along in with each other. So if you notice a CBC and you see that our lymphocytes are elevated, that means that a patient probably has a viral infection. If you're looking at a CBC and the neutrophils are elevated, that means that our patient probably has a bacterial infection. So that's something that you could start recognizing before you're even required to perform any microbiology or virology procedures. So let's talk about that again. So neutrophils, bacteria; lymphocytes, viruses; eosinophils, parasites. So our CBC could actually tell us a lot about what kind of infection we might possibly have. So once we know how our body can combat viruses, we know what viruses are made of. The next thing that we're going to be needing to do is classify our viruses. So the taxonomy of viruses are as follows. First, it's classified into an order, then a family, then a subfamily, and then the genus and species. So some of you guys may remember back to Microbiology, where we have an organism like Staphylococcus aureus. The genus is the first name usually, so Staphylococcus would be like the genus, and then the species is aureus. So that's how we also would classify our viral diseases. And I think I have some examples of this on the next page, so let's just get on to it. No, I guess not. I'm just gonna have a quick look here. Nope. So I'm just going to give a quick brief overview here because you guys are going to know in this lecture that we're going to cover different families, genuses, and so on and so forth. But it's very important for you guys as laboratorians to be able to connect the family with the genus, with the stranding of DNA, if it's enveloped or not enveloped. So like the family for the herpes virus would be Herpesiviridae. The genus would be herpes simplex virus 1 and 2. Other viruses in that family could be varicella zoster, Epstein-Barr, cytomegalovirus, so on and so forth. And then this family of Hepsiviridae are double-stranded viruses, and then they're also enveloped. So if we could classify our viruses into a family, then we could kind of figure out if they're going to be double-stranded like the other viruses in that family, or if they're going to be enveloped or not enveloped. So again, here we are able to organize our viruses into a DNA or RNA virus. We're able to organize them into something that might be double-stranded or single-stranded. We could classify them into a circular or linear virus if they have a positive or negative sense. The capsid structure, it could be a helical structure or helical, and then it could be enveloped or non-enveloped. And then non-enveloped viruses are known as naked. So here we're just going to discuss a little bit of the diagnostics of a viral disease. So we could do direct detection of a virus with immunostaining light microscopy or electron microscopy. So what's happening here is we're actually looking really at our samples and we're going to magnify them extremely low because you remember our largest virus is 300 nanometers. So we have to look through a nano type microscope to see if we could detect these viruses. Most laboratories now are gonna do molecular diagnostics. So what happens is it's gene amplification. So we're gonna do things like polymerase chain reaction or nucleic acid sequence-based amplification or branched DNA. And most of the time, it's just we're just gonna introduce a sample into a machine. This machine's gonna do this amplification for us, and then it's gonna classify these organisms based on their genetic sequencing or protein structure. We could also do serology. So these are detection and the measurement of antibodies. So what we're doing is we're essentially looking for antibodies to certain viruses to see if we have a current infection. So we could do radioimmunoassays, enzyme immunoassays, complement fixations, latex agglutination, and immunofluorescent assays and hemagglutination inhibition. For a lot of the viral diseases that we test for in our laboratories, like we do a mono test. That's going to be a latex agglutination test. But then if we have other viruses where we're going to have to do a specific sample, most of those are going to get sent to state laboratories, and the state laboratory is going to do its DNA amplification and PCR for us. Okay, so next we're going to discuss viral pathogenesis, and essentially this is what kind of pathogenesis or what kind of pathogen is this virus going to be? What kind of disease is it going to cause? So the methods in which viruses are able to inflict damage to a host organism is varied. That's what we mean by pathogenesis. So how does it vary? Viral replication can result in cytolysis, so destroying of our cells. It could also release subsequent release of virus particles. It could also account for areas of tissue necrosis. So, a virus can actually cause our tissue to start deteriorating or become necrotic and dying. The expression of viral antigen on host cells, which have been infected by a virus, can lead to immune response in which those affected cells are destroyed by cytotoxic antibodies, complement activation, cell-mediated destruction by natural killer cells, ADCC cells, cytotoxic T lymphocytes. So this immune response is going to give us our signs and symptoms of the disease. So these signs and symptoms aren't going to directly affect the virus, but it's going to cause um, infections, or it's going to cause symptoms of us. So whenever we have a high fever or our, when we have a respiratory issue, that's because of the pathogenesis, how our body's reacting to that virus infection. So the first family that we're going to discuss is the herpes viruses, or the family of Herpesiviridae. So herpes viruses, remember, we could classify it by their DNA. So a herpes virus is going to be a linear, double-stranded DNA with capsid and an envelope. So essentially that virus is going to be double-stranded. It's going to be linear, so it's going to look like this drawing here. It's going to have its regular capsid, and then it's also going to be enveloped. This isn't an exact image of what the virus is going to look like, but essentially it kind of gives you a little bit of a visual here. We've got the linear DNA with the capsid and then an envelope. So herpes simplex viruses, they're latent cells of the nervous system. We have the most common ones that are infected with individuals are herpes simplex 1 and herpes simplex 2. So what we mean by latent cells of the nervous system, we could be infected with herpes virus, but we're not going to know that we have an infection right away because there's a period of latency where that infection before it actually gives us lets us know that we have an infection. It's very important that you guys know the difference between herpes simplex virus 1 and herpes simplex virus 2. Herpes simplex 1 is the virus that causes oral facial lesions called fever blisters or cold sores. And then herpes simplex 2 virus is the one that causes genital lesions. So this is our genital herpes. Both types have been isolated from both sites. It's a very common infection with up to 80% of individuals infected with HSV1 and 20% with HSV2. So 80% of the population is infected with HSV1 and they could have cold sores, and then we have 20% with the genital herpes. It's important to note that these different types are transferable. So if somebody's performing oral sex on somebody and they have a cold sore, that patient could develop herpes infection in the genital area, but it's going to be with herpes simplex 1. Or you could also get genital herpes from oral sex because you're transferring an HSV2 that was located on the oral facial area. This is just a picture of a cold sore. So this is a lip blister from herpes simplex 1. And I don't have a picture of the genital herpes because we don't need to see that or discuss it in class. So the treatment of herpes simplex viruses is going to be something like Abreva, lysine supplementation. Usually what it is it's just an antiviral medication that's going to reduce the symptoms, but we're always going to have an infection. Well, not we, but people who have this herpes is going to be infected with this virus for life. So um, somebody who has cold sores is going to have reoccurring infections. Somebody with genital herpes is going to have reoccurring infections. It's never just fully goes away. It's with you for life. Herpes is for life. Diagnosis. So CPE develops rapidly in 1 to 3 days. I guess it's we don't really need to get too much into the diagnostics of it because most of the time a diagnosis could be made just from looking at a cold sore or genital herpes. But we could also do antibody testing, and that's generally what we'll do in the laboratory is just take a blood sample, send it out, and we're going to be looking for antibodies. Another virus that's going to be classified under the Herpesiviridae family is varicella zoster virus, also known as VZV. This virus is double-stranded DNA, so that's what the dsDNA means. It's double-stranded DNA with an envelope. This virus is the causative agent of chickenpox, also known as varicella. It's characterized by a vascular rash and a spiking fever. It could be spread by aerosols, So that's why a lot of people nowadays are getting their kids vaccinated with chickenpox because it's spread very easily from aerosols. But generally, after an initial infection with chickenpox, it's going to go away. Um, but we can have dormant virus infections in our nerves, and if that dormant virus gets reactivated, it's going to cause shingles, and this is known as herpes zoster. It spreads along, involves sensory nerve, and rash appears on one side of the body with severe pain. So some people who had a chickenpox infection can eventually end up with shingles later on in life. But generally, we nowadays we just would vaccinate our children to get rid of this. This is a picture of chickenpox or varicella. Usually appears as pus-filled blisters on the face, scalp, and trunk of children. Most of us have had chickenpox. There wasn't really a vaccine when we were children, so we've all had it before. It's very itchy. This picture is a picture of the shingles. So this is a zoster rash. So it's blisters that tend to wrap around one side of the torso, neck, or face, and they're very painful, and the pain can remain long after the rash is gone. My dad actually had a shingles infection, and um, the rash was long gone, but he was still having pain up to 6 months later. So something you really don't want to mess with too much or come in contact with. The varicella zoster virus can be treated with antiviral drugs or shingles vaccine. Diagnosis is going to be we could do a culture on a human embryonic lung fibroblast cells, and we could also do an immunofluorescence on a direct specimen from CPE. Again, most of the time, a doctor could just look at a patient and know they have chickenpox or shingles and do diagnostics then by that way. But we could also do other testing. Again, it could just be antibody testing, immunofluorescence. The next virus we're going to discuss in the Herpesiviridae family is the Epstein-Barr virus. This is an envelope double-stranded DNA virus. It's often transmitted through oral transmission, but also in blood and peritoneal uh, infections. So it could be spread perinatal infection, so it could be spread from mother to child. It targets the oropharynx, epithelial cells, and CD21 receptor on B lymphocytes. So oftentimes, whenever we have a Epstein-Barr virus infection, we're going to have reactive lymphocytes in our blood cells. So we'll get to this on the next slide. I'm kind of jumping the gun here, but this virus causes infectious mononucleosis. So with a patient with this infection, we're going to see fever, sore throat, lymphadenopathy, hepatosplenomegaly. It's associated with some lymphomas and cancers. Epstein-Barr virus, the laboratory diagnosis again here, this is where we'll get into it. We're going to see a high white blood cell count with lymphocytosis. This includes atypical lymphocytes or reactive lymphocytes, also known as Downey cells. And you'll be able to tell them because these reactive lymphocytes, they're lymphocytes, but they look like large monocytes that have a darker cytoplasm. So you'll be able to know if a patient has reactive lymphs. You should be able to tell the difference. We could also do a monospot test. Again, this is where we're going to do our uh, latex agglutination reactions to see if we have EBV specific antibodies. We could also see a production of heterophile antibodies that cross-react with antigens other than those induced to them. And then we could do enzyme immunoassays, immunoblots, fluorescent techniques. So again, we'll just take a blood sample, send it to a lab that are going to do all these techniques on a machine. The next virus we're going to discuss is cytomegalovirus, also known as CMV. This is a double-stranded DNA virus. It can be transmitted from breast milk, sexually, organ transplantation, transfusion, or contact with an infected individual. It's most common cause of congenital infections. So infection of fetus can be asymptomatic or fatal. Many individuals have latent infection and shed virus in low numbers, and it can be life-threatening to the immunocompromised. One of my friends actually had a baby who had gotten a CMV infection, and that resulted in the baby being deaf or slightly deaf. So it can be really important to know if we have a current CMV infection because it can be transmitted through breast milk. Diagnosis, again, we're going to do PCR techniques, direction of viral nucleic acid in whole blood or plasma by enzyme immunoassays. We could do isolation of the virus from human body tissues as a confirmation test. So we're going to look at lung fibroblast cells, and it's going to produce a large basophilic intranuclear inclusion called an owl eye. And again, this is something that you're going to be able to look at the cells and know that it's there because it's called an owl eye. So, and it's basophilic. So what does that mean? It's kind of a dark azure purple color. Serological testing can have cross reactions and cannot tell if it's an active infection. So again, this is where we're going to want to do like our PCR and our molecular diagnostics testing. I try not to get too in depth with our testing for viruses because most of the time it's going to get sent to a state lab no matter what state you're in. You're just going to collect the sample, send it to the state lab because any kind of a viral infection is something that they're going to have to work with and their epidemiologist is going to have to work with. So here is a stained lung tissue from an individual with AIDS, and it demonstrates the characteristic owl eye inclusion with an infection of the cytomegalovirus. So you could see that owl eye in that cell there. That's a CMV infection. All right. I know we're already 30 minutes in, but you guys are just gonna have to bear with me. We got 100 and more slides to go, but we're just gonna try and touch over the basics here and just keep moving. So Poxvirinae is the next family we're gonna discuss. This family includes an envelope double-stranded DNA viruses. Poxvirinae is the causative agent of the smallpox virus. So it's the etiologic agent of variola or smallpox. It's a highly contagious skin disease, characteristic lesions. Variola major has a 30% mortality rate. Variola minor has a mortality rate of less than 1%. Survivors may be blind and have persistent skin scarring or pox marks. So this is the virus that they tried to infect Native Americans with back in the day. So here's your cultural reference for this course. A severe case of smallpox in a Bangladesh child is featured here in this picture. So it's just important to note that Poxvirinae is the family for the smallpox virus. So in 1796, Edward Jenner developed a method of vaccinating using cowpox virus. So this causes the eradication of the infection in 1979 with the vaccination. Smallpox is now just listed as simply as a potential bioterrorism agent. For diagnostics, we're going to be looking through an electron microscope for visualization of the virus, and then serology testing can confirm diagnosis. So at this point, smallpox is eradicated. It has been wiped out because of vaccinations, but it is still can be a bioterror agent. So this is just a picture of a negative stained electron micrograph, and this is the variola virus here, the smallpox virus. The next family that we're going to discuss is Papillomaviridae, and this is where the human papilloma virus is going to be included in. Most of you guys have heard of the human papilloma virus, especially women. It's a double-stranded DNA virus. It's the most prevalent sexually transmitted disease. So out of all of the other sexually transmitted diseases we've covered in our other courses, human papillomavirus is the most common. It's associated with papillomas known as benign skin warts on the soles of the feet, the face, around the fingernails, as well as the anal and genital warts areas. Type 6 through 11 are associated, are 6 and 11 are associated with genital warts, also known as condyloma acuminata. And then type 16 and 18 are implicated as the etiological agents of cervical cancer. There is a vaccination out there now for human papillomavirus. Most people are offered this when they're in their between 21 and 24. So I've never been vaccinated for human papillomavirus, but I highly recommend it for those of you who are in that age range. Those of us who are a little older, yeah, just be careful. 50% of sexually active males and females acquire HPV during their lifetime. HPV can be detected during pap smears. Gene amplification techniques have been developed also. And then there's also the new vaccine, and it's approved by the FDA, and it's active against the strains 16 and 18 only. So it's only active against the strains that cause cervical cancer. It's not going to prevent you or protect you from genital warts, but it is something that we should be considered, especially females. The next virus we're going to talk about is under the family Adenovirdae. So adenoviruses are non-enveloped viruses. They're isohedral, double-stranded DNA viruses. They're associated with self-limiting respiratory, ocular, and gastrointestinal diseases. Infants and children can transmit disease by fecal-oral route and it causes diarrhea. Adults transmit the disease by a respiratory aerosol, so it can cause pharyngitis and colds in our winters, spring, and early summer. I come in contact with the adenovirus very often because I'm easily susceptible to this virus because I am a smoker. So generally, if you see me in the early winter, early spring, or early summer with a cold, it's because of I have an adenovirus infection because I'm a smoker. Adenoviruses can be caused from outbreaks in daycare centers and schools. Severe disseminated disease can happen in neonates, transplant patients, patients with Epstein-Barr virus, and patients with a HIV co-infection. So basically, somebody with a weakened immune system, such as a transplant patient or an HIV patient, or somebody with an underdeveloped immune system, such as a neonatal, can get a severe disseminated disease from adenovirus. For diagnosis, we're going to do immunofluorescence, electron microscopy, cultures, PCR, and serology. Just like every other virus that we've been discussing, most of the time we're just going to take a swab and send it to the state lab. But it's important to know these viruses, if they're double-stranded DNA, single-stranded, their structure, if they're enveloped or not, and then what disease they cause. As laboratorians, we're going to be tested on all of that, especially in our board certification exam. So that's why we're getting into a lot more detail with it in this course. Here is a transmission electron micrograph of adenovirus, and it's colorized. So this is just something that you could see. Only if you work in a public health lab are you going to be able to see viruses like this. It's not something we generally see in a regular laboratory. With the adenovirus, a specimen of choice is going to be a nasopharyngeal or throat swab or a bronchial alveolar lavage. For the gastrointestinal illnesses, stool specimens are going to be collected, and then we could prevent this virus through inactivated virus vaccines. It's attempted, but it's not for sure treatment or prevention. The next family we're going to discuss is the Hepaadenovirdae virus. This is where the causative agent or the family that hepatitis B virus or HBV belongs to. And we're going to discuss about HBV separately because it belongs to the family of Hepaadenovirdae. But unlike the other hepatotropic viruses or viruses that affect the liver, this viral genome of this specific virus is composed of DNA, and it's isohedral virus that it contains an outer envelope and surface protein. The surface protein is known as HBsAg. It also has core proteins. Those core proteins are known as HBcAg and the HBeAg. And it also has a DNA polymerase. So this envelope DNA virus is very hardy. It's able to survive at room temperature for up to 6 months at temperatures as high as 60 degrees Celsius for up to 4 hours. And the toxic effects of most disinfectants it's resistant to. So infectivity is rapidly destroyed by sodium hyperchlorite or bleach, and for this reason we dilute sodium hyperchlorite solutions as a disinfectant in healthcare setting. So most of you guys know that we have that bleach cleaning sample in our laboratory. Part of the reason for that is because of viruses like hepatitis B are susceptible to it. So the outer envelope surface protein is again hepatitis B or HBsAg, and then the core proteins are HBcAg and HBeAg. The reason that I repeated that is because those that outer protein, and those core proteins are going to actually be the proteins that we test for in the laboratory. So these are the ones that we're going to, you have to know the difference between them, because if they're ordering a core protein, the sample may be different for the envelope protein. So it's very important to know the differences so that you know what sample the doctor is ordering. In some cases, the doctor may be ordering uh, the envelope protein to get a diagnosis, but then they're gonna order the wrong core protein, or they're gonna order a core protein to do a diagnosis when they should actually do an antibody test instead, or some. It's just important to know the laboratory procedures and what is the standard for that specific laboratory. So this is hepatitis B is known as a surface or a serum virus. There's three forms that can be found in blood in infectious individuals. We have small spherical forms composed of the HBsAg only, and it's not infectious. We have long filamentous forms, which are vary in length and composed of the HBsAg and is also non-infectious. And then we have the infectious Dane particle and the HBV viron. So again, it's important to know what we're testing for, because some of these different strains or different tests might be non-infectious. So we could have them present, but they're not useful for us. So diagnosis is primarily through serological testing. So HBsAg is the first indication of a possible infection. And again, that is going to be the envelope surface protein that we're going to want to test for. It appears during incubation period and during an active infection. It could also can indicate an acute carrier. Then we could also test for IgM anti-HBC, which appears 2 weeks after an HBs antigen is detected. We could also test for IgG anti-HBC, which appears during the 8th week and persists for life. So and we also have an anti-HBE, and that appears 5 months and declines at 10 months. So it's very important to know that if we're going to look for an initial infection or to see if somebody has HBV, we're going to want to test for the HBsAg first. And then the other testing is going to vary depending on how far along that disease has progressed, whether it's 2 months, 8 weeks, or 5 months. Anti-HBs appears at 6 months, may persist for life. It's protective against infection, and it confers immunity to infection. So most of you guys have had to have this hepatitis B vaccination series, and it's a 3-part series. And then what you guys are actually being tested for is the anti-HBs, so that we can confer immunity to make sure that you guys are immune to an infection. It can be transmitted through blood products, body fluids, and secretions. So it can be transmitted from saliva, urine, tears, cerebrospinal fluid, semen, vaginal secretions, and breast milk. It could also be transmitted as a vertical transmission from a mother to an unborn child. It could also be transmitted to a mother to a neonate through vaginal secretions and breast milk. And it may be transmitted through tattooing, body piercing, intravenous drug abuse, needle sticks, and dialysis, and blood transfusion. So, I mean, hepatitis B can be transmitted a million different ways. So there's different types of infection. We could have an acute form. The incubation is 2 to 3 months. We could have an acute illness of 1 to 4 weeks and recovery at about 6 months. Or we could also have chronic hepatitis, and there we're going to see elevated liver enzymes that are going to be persistent for more than 6 months. So chronic hepatitis it's a benign disease in which the liver enzymes eventually return to normal, but an individual is going to continue to carry the virus. A chronic active hepatitis is where serious liver disease that can lead to replacement of healthy liver tissue with fibrotic tissue, also known as cirrhosis, could lead to hepatic failure and hepatocellular carcinoma. So this could eventually lead to liver cancer and then eventually death because of the liver cancer and cirrhosis. This virus is endemic throughout the world. And again, it's one of those viruses that where there is a vaccination available, and we want to make sure that we have immunity to it before we get to work in a healthcare setting. Okay, so now we're going to get into RNA viruses. RNA viruses can be single-stranded or double-stranded RNA. Most are single-stranded RNA. RNA stands for ribonucleic acid. Most of you guys should know that. So the RNA is their genetic material. It's what it's made up of. There are some medically important viruses that are included in this family. This would be include the hepatotropic viruses, so the viruses that infect the liver. We have influenza viruses, retroviruses, such as the HIV viruses, and the filial viruses, such as Ebola and Marburg viruses. So hepatotropic viruses are viruses that cause hepatitis or an inflammatory condition of the liver. Signs and symptoms associated with these viruses are going to be fatigue, fever, joint and abdominal pain, vomiting, anorexia, dark urine, hepatomegaly, which is an enlarged liver, elevated liver enzymes, and jaundice. How we would determine if we possibly have an infection with this, it would be like an elevated liver enzymes, so a liver function test diagnosis. So usually, if we have elevated liver enzymes and they're continuous, most physicians or most places are going to look for a hepatitis B or C infection first, and then branch out from there if those come back as negative. There's six different types of hepatotrophic viruses. There's hepatitis A, hepatitis B, hepatitis C, hepatitis D, E, and G. And they're all just listed as like HAV for A and HBV for B and HCV for hepatitis C, so on and so forth. Other viruses, all such as EBV, CMV, and HSV, could also cause hepatitis. Usually, they're going to specifically infect liver cells. The first one we're going to discuss is hepatitis A virus or HIV. It's an enterovirus and it belongs to the family Picornaviridae. Mode of transmission is going to be from fecal oral route by ingestion of food and water with contaminated with feces, and occasionally it's going to be parenteral transmission. So it's important to note the differences in these different types of hepatotrophic viruses so that you could kind of differentiate them and classify them. So it's important to know that hepatitis A is a fecal oral route virus. So hepatitis A, it's called infectious type hepatitis because it occurs in outbreaks. It often affects large numbers of people. So again, it could be an endemic infection. It could be acute, chronic, and or it could be an asymptomatic infection. So with an asymptomatic infection, there's going to be no clinical symptoms, but liver enzymes are slightly elevated. The incubation period is anywhere from 2 to 6 weeks. You're going to see a flu-like illness and pain in the area of the liver, and then viral shedding is going to take place for up to 30 days after the onset onset of symptoms, and then it's going to resolve itself within 6 months. There's anti-HAV antibodies emerge at about 10 days. IgM antibodies peak at 30 days and are undetectable at 6 months. IgG antibodies emerge at 14 days and peak at 30 days, and they can remain detectable for up to 10 years. So it's kind of important to note this because we're not going to know if we have a current infection if they're going to remain detectable for up to 10 years. Dem Diagnosis is going to be a demonstration of a significant rise in the titers between an acute and convalescent sera. So what we're going to do is we're going to want to collect multiple samples to see if we have a spike in the number of antibodies present and to see if we have a current infection or an older infection. There's no specific treatment. Rest is recommended during the acute stage of the illness. Immunity is conferred by the production of neutralizing antibodies directed against HAV. HAV vaccine can be administered to prevent infection in uninfected individuals who have been exposed to the virus. The next virus that we're going to discuss is the hepatitis C virus. This one belongs to the family of Flavividae, formerly known as non-A, non-B hepatitis. Its mode of transmission is primarily parenteral, which means it's a bloodborne pathogen, or it could be distributed from perinatal and sexual transmission um, is possible. 20% of cases are acute, 80% can cause a chronic infection. It causes cirrhosis and liver cancer, and it's the leading cause of liver transplants. In Native American areas such as or areas where there's a lot high poverty. Hepatitis C infections happen quite a bit because they could be transmitted from unprotected sex or IV drug use. Diagnosis primarily is based on demonstration of elevated liver enzymes such as the ALT. It's exclusion of known viral etiological agents, EIA procedure to screen donor blood for the anti-HCV antibodies, and then treatment is going to be antiviral drugs such as ribavirin or immuno immunomodulatory drugs such as interferon alpha. So most of the time before somebody could be treated with a HCV infection, they're going to have to demonstrate a lifestyle change for at least 6 months to a year before a doctor will even consider treating them for this disease, because we don't want to treat a patient with interferon alpha because it's a very expensive procedure and it's actually very harmful. So we don't want to waste our time treating patients who are just going to possibly reinfect themselves or drink themselves into hepatitis again. So the next virus we're going to discuss is the hepatitis D virus. It's a defective virus because its genome lacks essential genes. So it's probably subviral agent because it requires a helper virus, such as HBV. HDV infection can only occur in individuals which an HBV infection must be transmitted simultaneously with a HBV or as a superinfection of HBV infected individuals. Transmission is perienteral like HBV. HDV infection increases the risk of cirrhosis and cancer. So an infection with HDV increases the risk of cirrhosis or cancer. Diagnosis is IgM antibodies appear for the first 6 weeks after infection with a decline after acute phase. IgG antibodies appear during acute phase and decline within a few weeks. Both the IgM and IgG are elevated in cases of chronic infection. Diagnosis depends on the detection of antibodies to HDV antigens. The next virus we're going to talk about are the Picorna verde or enteroviruses. These are the poliomyelitis viruses. They're single-stranded RNA viruses. They're the etiologic agents of polio, especially in children, and it's transmitted through fecal-oral route via ingestion of contaminated food and water. Multiplies in gastrointestinal tract and then invades blood and finally the central nervous system, causing irreversible paralysis. 95% of cases are asymptomatic, and the vaccine has eradicated it in developing countries, but is still a significant threat in third world countries. So the Picorna verde family is the poliomyelitis virus family, and it causes polio. Simple enough to remember, right? The Picorna verde family also includes the rhinoviruses. This is the major cause of common colds, primarily during the fall and springs. It rarely causes bronchitis and pneumonia, but it does cause them. It's very hardy, heat stable, and resistant to the effects of desiccation. Factors associated with transmission is going to be close proximity of individuals in cold weather, viral shedding and nasal secretion before symptoms. Shedding persists for several days after recovery, and half the cases are asymptomatic, but it still sheds the virus. So one of the reasons that I get not only do I get colds very often because I'm a smoker, but I also get these infections every year from whenever I travel. Because if you're in close proximity to somebody who has an infection, like an airplane, then you're obviously going to come into contact and possibly get infected. So a little continuation here. Hands of infected individuals transfer nasal secretions to inanimate objects. Self-inoculation of uninfected persons can happen by rubbing eyes or nose. Control through hand washing and avoid contact between eyes, nose, and hands. A vaccine is not likely due to the different numbers of serotypes. So there's so many different types, serotypes of rhinovirus that we can't accurately vaccinate somebody because they could come in contact with thousands of different types of serotypes and get another infection. So it's just not possible. And then laboratory diagnosis rarely attempted because of the mild nature of the infection. It's usually self-limiting, so everybody tells you just to let it run its course. The next virus we're going to talk about is coronaviridae. So coronaviridae viruses are enveloped. They're single-stranded RNA viruses. They cause the pharyngitis and most colds during the winter months. Transmission is through respiratory secretions. They cause severe acute respiratory syndrome, also known as SARS, which emerged in 2003. This is associated with fever, chills, malaise, headache, pharyngitis, rhinorrhea, and diarrhea. Cough, shortness of breath, and difficulty breathing. So most of you guys have heard of SARS before. Diagnosis, so a history of travel to the Far East, also referred to. So when we talk about the Far East in this course, and I probably should have mentioned it earlier in the course, we're referring to China, Taiwan, Hong Kong, the Asian continent or Asian areas when we say Far East. Exposure is known to cause SARS. It, specimens that can be collected are nasopharyngeal, oropharyngeal, bronchial alveolar lavage, and lung tissue testing. The tests we're going to do are immunofluorescence, nucleic acid assay, serology, but it's difficult to grow in a culture. Prevention, so early recognition of infected patients, hospitalization when necessary, contact and airborne infection, isolation precautions, and cough etiquette. So whenever we refer to cough etiquette, it's simply just covering your mouth when you cough because you're going to help reduce the risk of spreading these airborne droplets. Treatment, there's none available at this time, but there's a possible vaccination being investigated. Orthomyxoviridae, also known as the influenza viruses. These are enveloped, single-stranded, segmented, and negative sense RNA viruses. Projections resemble spikes embedded in lipoprotein viral envelope. So we have hemagglutinin A, H, major glycoprotein of influenza virus responsible for attachment to host cells. And then we have neuraminidase N, and this is a glycoprotein enzyme on the surface of the virus and is responsible for the release of the viral progeny from the cell. Influenza viruses are able to escape host defenses through antigenic variation. Segmented viral genome can be restored to yield new viral particles expressing new combination of surface antigens. And then what we need to know here mostly is that influenza A is the most implicated in pandemics. So pandemic is a worldwide infection. So things like the Spanish flu, Asian flu, Hong Kong flu, avian flu, and then swine flu or H1N1. Types A and B cause life-threatening infections to humans. Most cases of the flu are self-limiting. Complications such as bronchitis and pneumonia can be very serious to infants, elderly, and chronically ill patients. These viruses usually appear in November to December and linger through to March or April. So generally, that's why we start doing the flu viruses in the late fall and continue the flu virus vaccinations. And the reason for that we have a different vaccination each year is because we're generally guessing what type of serotype is going to be the infectious type that year, and we're going to try to prevent infection with it. Transmission is through respiratory aerosols. Pandemics are associated with antigenic shifts, so they occur when change from one hemagglutinin or neuraminidase to another occurs, results in the emergence of new virus particles. An antigenic drift is due to minor changes, so point mutations on the amino acid sequencing of hemagglutinin or neuramidases. Subtype remains the same, even though small changes gives virus selective advantage. So what's happening is that these viruses, what we're saying here is that these viruses are smart. These viruses can make a single change in their amino acid sequence of their DNA, and it could cause a totally different disease or another infection or a reinfection. So it makes it really hard to treat and totally get rid of these viruses. So they're a little bit more virulent. Influenza type A, it's found to infect swine, horses, birds, and other animals. Asian flu and Hong Kong flu caused by strains resulting from reassortment of human and avian viruses. Wild birds are the only animals having all subtypes of influenza A. H5N1 strains are able to merge genes with strands found in hosts such as humans and birds. H5N1 is the etiological agent of the avian or bird flu. In 2003, strains of H5N1 were responsible for an outbreak in Southeast East Asia. Outbreak continues to this day as a major cause of concern because its increased virulence in humans, infection acquired by close contact with fowls, so birds. No cases of human-to-human transfer documented at this point, so we can't really transfer it to each other. We have to have contact with the same infected bird or fowl. The infection is usually asymptomatic or mild. Symptoms include fever, chills, malaise, sore throat, and cough. Uh, Fatalities associated with viral pneumonia and secondary bacterial infection. Prevention, vaccination is the most effective method. Live attenuated vaccine or weakened virus is going to be introduced to us. Individuals with allergies to chicken eggs should not be vaccinated because the virus is propagated in chicken eggs. To diagnose this, it infects the respiratory mucosa, so the specimen of choice is going to be obviously our nasal washings and aspirates. Throat swabs can be used, but they contain less of the virus. So most of the time, when we do a viral culture and we say nasal pharyngeal, we're actually going to stick um, a swab in somebody's nose and go as far back as we possibly can. So it's nasal pharyngeal. During flu season, microlabs are inundated with specimens for rapid immunoassays. Monoclonal antibody assay detects either influenza A and B or both. Sensitivity is about 80% due to poor specimen quality. So it's only at 80% sensitivity for detecting this virus. Influenza B, it causes milder upper respiratory disease in younger children. Complications such as pneumonia are rare. And then Ray syndrome with use of salicylates is used to reduce the fever in children. Influenza type C is associated with common mild illness in early childhood. Vaccination confers immunity to specific strains or subtypes. Abrupt changes in this virus or the surface antigens on the virus occur. So immunity to one strain doesn't prevent susceptibility to another strain. So again, whenever we're doing vaccinations each year, it's because we're just these organisms are changing their antigenic variations. So we're just kind of guessing which variation we might have an infection with that year. Those at risk for complications and healthcare workers should be vaccinated. So whenever you guys are offered a flu vaccine and you're working, you should probably take it, even though some of you may be less inclined to, because it's gonna help you because you're gonna come in contact with it a lot more than most other people because you work in a healthcare setting. The next family we're going to talk about is the Parasitology family. The Paramyxovirus family are enveloped helical RNA. So it's kind of like a DNA in that helical shape, but it's RNA. We have respiratoviruses genus, which causes the parainfluenza virus. We have the pneumonia virus genus, which causes the RSV disease, respiratory syncytial virus, and then we have the metapneumonia virus. We also have the Morbillivirus genus. This is the measles virus, and it has canine distemper virus. And then we have Rubeola genus, which causes the mumps virus. So the Paramoxoviridae family is the family that causes RSV, measles, mumps, and rubella. So the parainfluenza virus, it's an acute respiratory illness in children. It causes croup or an upper respiratory infection, causing laryngitis and associated with human hoarse cough like the bark of a seal. Causes pneumonia, bronchitis in infants, transmission via inhalation of droplets or person-to-person contact. No vaccine or effective treatment. A couple of years ago, when I last taught this parasitology course, I actually had to cancel class twice because my godchild had a croup infection and he infected me, and I developed a parainfluenza virus, which caused me to lose my voice for nearly a month. So I wasn't able to lecture. Luckily, it was towards the end of the class. Diagnosis is we're gonna do throat swabs and nasopharyngeal washing, direct fluorescent antibody to demonstrate virus in respiratory secretions. We could do cell cultures, so we have a primary monkey kidney, human neonatal kidney, or human lung cancer. It could take up to 14 days for the cell culture. Immunofluorescence or heme absorption on cells is exhibiting CPE. Um, let's just try and keep in mind that for virology, most of the diagnoses we're going to do is take a nasal pharyngeal swab and send it to a state laboratory, and I mentioned that before. Respiratory syncytial virus, or RSV, is named for its characteristic cells. Syncytia are associated with cells merging to form large multinucleated cells. It's a major cause of upper respiratory disease in infants, range from mild disease to bronchiolitis and pneumonia to severe respiratory distress and death. We've actually had a couple of cases of RSV associated infant deaths in our area, so it's important for you guys to note this virus because it is something that we come in contact with here. Increased risk of RSV pneumonia is for premature infants or those with congenital heart defects or chronic lung disease. Pneumonia increases risk of asthma later in life. So those preemies who have undeveloped lungs are more likely to get infected with this virus. RSV, most infections are late winter and early spring, and it peaks in February and March. Nursery outbreaks associated with high infection rates and some fatalities. Transmission via direct contact with respiratory secretions. So hand washing is very important, just like any other virus and bacteria. We want to make sure we wash our hands so that we're not coming in contact with these respiratory secretions. This is just a duplicated slide, it looks like. Infections in adults are acute and may cause upper respiratory infection. They may be chronic and severe in elderly, can lead to bronchiolitis and pneumonia. There's no vaccine available, but ribavirin is an effective antiviral drug for RSV in adults. Again, we're going to want to do nasal washing or aspirates, and we're going to do a direct fluorescent antibody technique or enzyme immunoassays. So the measles virus, again, it's under the family Paramyxoviridae. It's an enveloped single-stranded RNA, also known as rubeola virus. It's a highly infectious disease spread by respiratory aerosols. It has an incubation period of 10 days. Symptoms can include fever, cough, runny nose, conjunctivitis, and generalized rashes. Um, Polix spots are bright red spots with white centers on the oral mucosa, are diagnostic, and if apparent, no laboratory diagnosis is required. Skin rash and copolic spots are diagnostic, and laboratory diagnosis is not necessary. So again, with most viruses, we're just going to look at the patient's symptoms, signs and symptoms, and most doctors are just going to say you have a viral infection, and they're not going to do any laboratory testing. If laboratory diagnostics is required, we're going to do a swab or urine sample. We could do cell cultures of human kidney cells, and what we're going to see is distinctive multinucleated cells. We could do serological testing for IgM antibodies in an acute phase of the infection, and then we could do enzyme immunoassays or serum neutralization assays to obtain antibody titers. Most of the time, we're going to see antibody titers with measles, mumps, and rubella in the laboratory. Vaccination is done for a means of protection. Prior to the measles vaccine, as much as 95% of the population were infected at some time during their life. Vaccination is given at the age of 18 months as part of the MMR vaccine, or measles, mumps, and rubella. And then the booster is administered before the 5th birthday. Most of you guys know that in order to attend a college, you have to have an MMR vaccination before you can attend college. It's a requirement for most universities, especially in North Dakota. Now, the mumps virus, it's an envelope virus, single-stranded RNA virus. It causes mumps or endemic parotitis and self-limiting systemic viral diseases. Transmission occurs via droplets of infected saliva. Symptoms can include painful swelling and parotoid glands, fever, headache, and sore throat. The pancreas, ovaries, and testes can become infected, and it can lead to infertility with a mumps infection. This is just a picture of somebody with a mumps. You note that salivary glands of the virus is going to cause the neck swelling. It makes it easily recognizable. We have had some cases of mumps in North Dakota recently. Specimen of choice is going to be saliva or urine. We're going to do direct detection from immunofluorescence. Diagnosis commonly made through serological testing to measure IgG and IgM. So we're going to want to see a fourfold rinse in the titer to get a diagnostic result for mumps. Again, we're going to want to immunize with MMR vaccine. The rubella virus is again an enveloped single-stranded RNA virus. It's a causative agent of rubella or German measles, also called the three-day measles or an epidemic roseola. Transmission is going to happen via respiratory droplets and inhalation. In young children, rubella is mild, and in most cases, it's asymptomatic. In adults, infection is more severe. Symptomatic infection can include fever, a rash on the face, trunk, or limbs, red papules on the soft palate, conjunctivitis, and lymphadenopathy. There could be a congenital infection associated with rubella. Transmission is going to happen from an infected mother to the fetus. With primary infection, there's no protective antibody to cross the placenta and protect the fetus. So in a congenital infection that occurs during the first trimester can result in severe developmental defects such as cataracts, glaucoma, deafness, congenital heart disease, mental retardation, spontaneous abortion, premature birth, and fetal death. A postnatal infection is going to be transmitted through breast milk, but is usually a mild disease. Diagnosis, we're going to want to do saliva or nasopharyngeal secretions in urine. It can be cultured on African green monkey kidney cells, but does not produce CPE. It's rarely used, but PCR and immunofluorescence is used to confirm presence of virus. So again, I'm going to just note that we're just going to do PCR techniques, and again, it's going to be done by a state laboratory. There's serological testings. We could do passive hemagglutination. So this is where red cells or latex particles are coated with the viral antigen, and then we're going to be testing for antibodies in the blood. Prevention, we can attenuate vaccine for children around 1 year old. It's part of the MMR vaccine, and a booster is again given before a child starts school. Okay, so I'm just going to breeze through these last 20 slides because these viruses are just noteworthy, but they're not that important. So we have RNA viruses are continued. We have rotaviruses, which are small, non-enveloped, double-stranded RNA viruses. They were discovered in 1973 during an investigation of several cases of infant gastroenteritis. Rota is the Latin word for wheel, and it describes morphology of the virus. So it's kind of a wheel shaped double-stranded RNA virus. So a double capsid is seen with an electron microscope. It resembles a wheel with a wide hub and short spokes radiating from the hub to the rim of the wheel. It's transmitted via fecal-oral route. Here's a picture of that rotavirus under an electron microphotograph, so you can kind of see what we just described on the last slide. Infection can be asymptomatic, mild, or severe dehydrating diarrheal illness. Symptoms include fever, vomiting, diarrhea, and dehydration due to water loss. Most cases in infants is going to be 16 to 24 months of age. Most common cause of severe diarrhea, leading cause of mortality. In developing countries, many children succumb to the complications of a rotavirus infection. Transmission is often via contaminated water or food such as oysters, clams, or raw shellfish. Treatment occurs of rehydration to prevent severe fluid loss. Frequent hand washing reduces transmission of new infections, and vaccinations are used to protect against severe diarrhea. The rabies virus comes from the family Rhabdoviridae. It's a single-stranded RNA virus. Transmission is via the bite of infected animals. It could possibly transplant surgery can cause a rabies infection. Virus shed in the saliva of infected animals such as dogs, cats, foxes, raccoons, and bats. The virus enters our peripheral nerves and travels to the central nervous system, and it causes encephalitis and myelitis. Rabies always fatal once symptoms appear. Symptoms may take months to show. Pain at the bite site, flu-like symptoms. The CNS invasion is associated with insomnia, anxiety, confusion, hallucinations, hydrophobia, and eventually the host succumbs to coma and death. So usually we have a rabies vaccine that we take, or if somebody has recently been bitten by some kind of an animal that may be contaminated with rabies, we're going to want to vaccinate that patient right away to make sure that we can try to prevent that death essentially. Treatment, viruses must travel from bite site to the brain and spinal cord to cause serious damage, but it's extremely slow. So post-exposure treatment consists of vigorous cleansing of the wound site. Administration of the vaccine and immunoglobulin is extremely effective in providing protection from lethal effects. Diagnosis, we're going to do a biopsy of the brain demonstrating the presence of Negri bodies seen in 70 to 80% of cases. Negri bodies are eosinophilic inclusions in the cytoplasm of the neurons. So obviously our patient has to be dead if we're going to be doing a brain biopsy. EIA testing to detect antibodies. We could also do a rapid fluorescent focus inhibition test for antibodies. Flow cytometry could be used to detect rabies virus antigen in infected cells. EIA testing to direct antibodies. Oh, this is a repeat slide. I'm sorry about that. Flow cytometry could be used to detect rabies virus antigen in infected cells. It's used because it's automated and it's quicker. So emerging viruses, this book that I'm using is a little bit older because I'm not lecturing out of the Coleman's Color Atlas because it's way too detailed. I'm actually lecturing out of an old clinical laboratory microbiology book from my college years, but you should still take a good look at the Coleman's Atlas because it's going to break everything down for you pretty good in the charts and the graphs. So hantavirus, we've heard about it. It's been around for a while. It's an RNA virus in the family of Bunya It produces two distinct types of diseases. It could produce hemorrhagic fever and severe pulmonary disease. Transmission occurs in aerosolized urine and feces of rodents. It appeared in 1993 in the Four Corners area of the United States, Arizona, Colorado, Utah, and New Mexico. Recently, we have heard of some deaths from hantavirus in the upper Midwest in our area. So it's important for us to recognize how it's transmitted and how it's treatable. So hantavirus, pulmonary syndrome fills lungs with fluid so the patient literally drowns. Has a potential bioterrorism agent. Rift Valley fever virus is under the same family. It's found in cattle in Africa. Transmission is via mosquitoes or contact with animals. And this uh, virus can cause ocular infections, meningoencephalitis, or hemorrhagic fever. Filoviruses is under the family Filoviridae and includes Marburg and Ebola viruses. So the family Filoviridae is where our Ebola virus comes from, the one that we heard about really recently, within the last couple of years. Potential sources of infection may be African monkeys and fruit bats, but it's unproven to date. It causes hemorrhagic fever and it's usually fatal. This virus requires a biosafety level 4 lab or BSL 4 lab for testing. Those of you guys who have had microbiology have heard of these laboratories. Those of you who haven't should look up what the requirements are for a BSL 4 laboratory. Potential use as a bioterrorism agent. HIV and AIDS. They're enveloped RNA viruses from the family Retroviridae. They're also known as retroviruses. Clinical manifestations of HIV were first reported in 1981. It's the virus that causes acquired immunodeficiency syndrome or AIDS, and it was named HIV in 1986. The World Health Organization estimates some 37 to 45 million were infected with AIDS by or HIV by the end of 2005. HIV can be transmitted through several routes: percutaneous injuries such as needle sticks, broken glass, and improper disposal of sharps. IV drug IV drug abuse can be with contaminated needles, mucous membrane exposure, such as splashes into the eyes, nose, and mouth. I have actually been in contact with HIV infected blood in Spirit Lake. I got really nervous when handling it and I spilled it all over my lab coat. So, since I was exposed, I often get myself tested every 6 to 12 months because you never know if it came in contact with your eyes, nose, or mouth, and sometimes it could take years to manifest itself. I've also done the same thing with somebody who had a HCV sample. I was very clumsy. It was my first couple of years as a laboratorian, and there's a couple of people in the Spirit Lake area that have HIV and hepatitis C. So it's important to be careful with your samples. That's why we stress splash guards and things like that, your protective equipment. Sexual intercourse with an infected individual, intrauterine infection, so transplantal transmission, and then blood transfusions. Most cases now appear among heterosexuals. So when those of you who, I'm sure everybody's heard about HIV before, it was primarily thought of as a homosexual disease, but now in the more recent years, most cases are now appearing among the heterosexual population. Factors associated with the spread through intimate contact include multiple sex partners, sexual practices resulting in mucosal trauma such as anal intercourse, use of recreational drugs including cocaine, marijuana, and nitrate inhalants. There's two species of HIV that infect humans, HIV-1 and HIV-2. It's important that you guys note the difference because, again, this is a quiz question. HIV-1 is prevalent throughout the world and is more virulent. HIV-2 is more prevalent in Africa. Diagnosis, we're going to do enzyme immunoassay testing as a method of choice to detect antibodies to HIV. Western blot is used as a confirmatory test to establish the diagnosis. HIV antibodies attached to HIV antigens attached in the nitrocellulose. A labeled anti-human antibody binds to the patient's antibody producing specific bands. So that's what happens in our Western blot testing. Nowadays, we actually have rapid tests that are done in most laboratories where we could do the testing as just a screen. But confirmatory testing is where we would have to do viral load testing. So somebody has a current infection with HIV on our screen, then we're going to do a viral load testing, and this is done by HIV reverse transcriptase, PCR, nucleic acid sequencing based amplification, and branch chain DNA testing. Um, we actually had a patient in Kandu who presented as HIV positive in the screening, but when we did the viral load testing, the patient was negative. So they technically didn't have an infection with HIV and it was a false positive. A single measurement of viral load does not provide clinically desired information. Therefore, change in viral load over time may be observed to determine success of treatment. In determining the viral load, the number of HIV nucleic acid copies per milliliter blood is calculated. The measurement is used to monitor HAART therapy during chronic viral infections and to measure severity of the HIV infection. Prevention, vaccine development has encountered many obstacles. There's an existence of many different HIV strains. There's M, N, and O, and it's on the basis of differences in the NV gene. HIV envelope proteins vary widely, so it just make it really hard to make an antibody to or make a vaccination to HIV. But now there's actually prophylactics available for people to take. I don't know exactly what it's called, but I know there are prophylactics out there where somebody who has risky behavior and can uh, are more likely to get exposed to HIV can take these prophylactics, and it kind of reduces the ability of somebody to get the disease. With HIV, also too, there's treatments now that reduce the viral load so low that the patient is virtually cured of HIV, but they could still have the opportunity to have that viral load increase and have a current infection again. So it's just there's a lot of information about HIV and AIDS out there right now, but we don't need to know all of it for our class. You guys will probably come in contact with it whenever you do your continuing education because that's where I get most of my information. Thank you for bearing with me with this lecture. Again, the quiz is based solely on this lecture, so encourage your classmates to listen to it. You could break it down, pause it, and listen to it in multiple attempts, but do listen to it because essentially what we did here in this lecture is we did an entire virology course in a short 114 slide lecture for your guys' convenience. So happy studying.